Uh, Assalamu alaikum, everyone, and good evening. On behalf of Sudavas, it's my pleasure to introduce to all of you Mr. Lim. Mr. Lim is a consultant vascular surgeon and an honorary clinical lecturer at the Royal Free in London. He's also an honorary consultant at Great Ormond Street Hospital, which is one of the main hospitals in pediatrics and pediatric surgery in the country and actually in the continent. He qualified from Parts and the London Medical School. He obtained then a PhD from the Imperial College in London. He went and completed general and vascular surgical training in London and undertook a senior clinical fellowship in complex venous disease at St. Thomas's Hospital. Mr. Lim is a specialist. He has a specialist interest in complex venous disease in general and vascular malformation. He has expertise in all aspects of vascular surgery, but he has great experience and expertise in specifically in vascular surgery in children. He's got lots of research in management of vascular malformations, and we are honored today to have you here, Mr. Lim. Thank you for in advance for your talk, and I'm sure everyone is gonna benefit from this talk, and hopefully will take this information forward. Without further ado, the floor will pass it back to you. Thank you. Mr. Lim, is just you're muted still.
Thank you very much, Mr. Haitham Hamid, for your kind introductions. First of all, I want to thank also Mr. Ayman Ahmad, Mr. Muhammad Awoda for the kind invitation for me to present to this webinar. And I also want to thank my ex-trainee, Mr. Khalid Ahmed, who kindly liaised for me to present here as well. So it's a great honor for me to present to you in terms of pediatric vascular malformations. I'm going to focus a lot more on the vascular malformations than the vascular tumor, but as you know, the whole thing is actually known as vascular anomalies. So vascular anomalies is a very big umbrella term, and it's divided into vascular tumors and vascular malformations, and they're fairly separate entities. But normally the team should be able to treat both of these conditions together. So we always start with the classifications when it comes to vascular anomalies, and we should use the ISWA classification, which has been there since the 90s and has been trying to refine it as much as possible. It's just to show that this is a very heterogeneous condition. It's not just one disease, but it's a huge variety of symptoms, pathogenesis, that can be quite challenging in some cases. So as you see in these slides, it is divided into vascular tumors and vascular malformations. The vascular tumors then further subdivided into benign, locally aggressive, or borderline or malignant. And again, on the other side, the vascular malformations, usually it's divided into the type of blood vessels that are involved. It could be purely a capillary, it could be a pure lymphatics, but quite often it's a combinations of different vessels. It could be capillary, venous, or it could be the all types of vessels that are involved. Then to make things even more complicated, then within the vascular tumors, and they're even subdivided to various different types. So they can be quite a lot, which I'm not going to go through everything in the talk today, because it is, there is a good, you can actually get it on the website if you want to look into the classification. The other thing I want to add is the more recent classification also adds this panel. If you can see my arrow, there's this blue writings here, which is the genes that are involved in some of this condition. This is now becoming pretty important because there are more and more genes being identified, and the implication of this is important because I think the future treatment for this condition will a lot more focus on medical treatment rather than surgical treatment. As you know, vascular anomalies historically is a surgical condition, but fortunately or unfortunately to the surgeons, this will be moving towards medical treatment. So I think as surgeons or interventionists, we should be, focusing on the medical side of the condition as well, not just, about the cutting it out or embolizing it. Again, the same, vascular malformations. There are venous malformations. Again, it varies into different types. There are names for some of this, and they can be very confusing. And also, some of these are associated with syndromes. They could be Klippert-Trenaunay syndrome, which is something we look after a lot at the Royal Free Hospital. But there are also, some rarer syndromes. Usually, some of them are associated with segmental overgrowth, means part of the body is bigger than the other side, or they can be involved other types of disease, or all come as a group of syndromes. I'm going to touch briefly on the vascular tumors because in the pediatric sites you do see quite a lot of vascular tumors. In fact, quite it is something very important from the pediatric side. As I said earlier, it can be divided into benign, locally aggressive, and malignant. The most common ones are the infantile hemangiomas, and then there are some like congenital hemangioma, which can be, rapidly involuting congenital hemangioma, or the one that are non-involuting, means they don't regress, or there are some which are just partially involuting. And the one that you see, like in this photograph here, if they are very extensive around the face, which we previously called birthmarks, you just have to be a bit more careful because, or in the pelvis or buttock, because usually there are some of them where they involve deeper than just, a skin birthmark. They could be affecting the brain. They could be affecting the internal organs within the pelvis. The treatment for this type of for vascular tumors, really depends on how it affects the child. What's the prognosis? It could be very simple, no treatment, whether the hemangioma or the vascular tumor will regress, or it could be something involving surgery, laser, embolization. Sometimes they can be quite challenging to operate on, or to do any interventions. Then we may consider treating them with medical treatments, like the common ones used are like the propranolol. Sometimes we use steroids, or even like cancer drugs like vincristine. And it's also important, not just about removing the lesion. The extensive one, they do have some medical complications. One of the notorious one is the coagulopathy in patients with Kaposiform hemangioendothelioma and tufted angioma, which is the phenomenon is called the Casabat-Maric. This is where the trapping of the platelets, by the vascular tumor or the hemangioma, which leads to the consumption of the platelets, which means the platelets are being all used up because they're all being trapped and they form they use the platelets, they consume the clotting factors, and this leads to these patients do not have enough, they have low platelets, they have low clotting factors. So they end up forming inappropriate clots, blood clots, and they also end up causing inappropriate bleeding. And you can see, as this is such, this condition is so complex, involve it needs to have medical expertise as well as surgical expertise. Usually, a multidisciplinary team care is extremely important. So I'm going to move on to vascular malformations. Vascular malformations can affect all blood types. It could be arteries, veins, lymphatics, or capillaries, and it affects all age groups. A lot of children can be affected. Sometimes they might not be very obvious, or they might not even have any symptoms, and the child grow up without much symptoms, not knowing, and then they might even present as an adult. It can affect any parts of the body. Um, by definition, it should be congenital, which means they are born with, and they could be caused by somatic or germline mutation. Somatic mutations is the most common. It's around about 90-95%, while the small percentage, 5%, are hereditary. And as I mentioned earlier, it could be syndromic or non-syndromic. How often are they? There's very limited data on this because it's such a heterogeneous condition. Some patients or some people might not even know they have it, and they just live the whole life without knowing they are there. But the very, very crude estimation of the prevalence and incidence of, let's say venous malformation, it's been estimated to be about 1% or 1 to 2 in 10,000 respectively. So it's actually quite common. If you think about it, if it's 1%, it's actually, reasonably common for a medical condition. And this is just venous malformation. And if you move to lymphatic malformation, it's about 1 in 4,000 live birth, which is less common than venous malformation. The rarest ones is probably the arteriovenous malformation, which is luckily, because this is usually the hardest one to treat. And it's been estimated the annual incidence per 100,000 for AVM itself, it's about 0.24 here. So these are just very crude estimations. As I say, this is many people probably don't even know they have them. In terms of clinical features or the symptomatology wise, they could be various. It really depends on where the lesion is. It could be just very cosmetically, it's disfiguring. It could be affecting the child from the developmental, issue, both physically and psychologically. The size effects is important. It could be pressing on another structure, the nerve, for instance, or it could be pressing onto the bowel. And pain is common. Some patients might be presenting with bleeding, ulcerations, coagulation problem. Patients with lymphatic malformations, for instance, might get infections, recurrent infections. Sometimes they can, be life-threatening. Even, if they're not affecting the patients physically, quite often they will affect their quality of life as well. So when we see a patient presenting with a possible vascular malformation, just like most things in medicine, taking a good history will be important. In the history, we tend to look into how it affects the person. What are the symptoms? How what sort of treatments the person had before? What are the expectations that the patients have? This is important. We'll mention it a bit later, because a lot of the treatment focus on, treating the symptoms rather than rather to try to cure the condition. And as physical examination is always very important. You examine, the size of it, the location, whether the complications, by just physically examine, you can tell whether this is a venous, lymphatic, or whether it involves the artery, i.e. the AVM, the arteriovenous malformation. Usually you can tell by just taking a good history and examine the patient, you can kind of make quite a lot of the diagnosis properly. I mean, these days often we also, add on the imaging side. The ultrasound is always a good scans to do because it's non-invasive, and it's actually going to give you quite a lot of information, the location of it, where the flow of the lesion, essentially, you know, a lot of the treatments really depends on the flow, whether it's high flow or low flow, even though that is not being, the term is not being used in the EASD classification. Very occasionally, we do a cross-sectional imaging if the lesion is very complex. But in children, you know, it's very challenging because, you know, babies or very young toddlers, they will not tolerate MRI or CT scan because they won't be able to lie still. Quite often we'll need a general anesthetics, which is, you know, carries some risk, and see things like CT do carry some radiations. Then the biopsy may be important. You know, the reason for biopsy is just to make sure you do not miss something. You know, there are surprises. Unfortunately, there are cases where, you know, benign tumors, some other benign tumors are being missed. One of the common one is the schwannomatosis, which can look like a venous malformation. You know, but more worrying is you do not want to miss a malignancy. So histology, we do at Row3, we are increasingly using histology because of that reason. I want to stress on coagulation assessment mainly because it has taken us by surprise in some cases where the patients, you know, develop massive DVT or PE, or another extreme, they just bleed continuously, you know, especially if you want to do an operations on them. I have a patient who I just excised, is a venous malformation, you know, about 10 days ago, and he's still bleeding from the wound, despite, you know, stitches, you know, holding all together, but it just keep oozing because he has no clotting factors. And we have to actually give heparin to try to stop bleeding, which is paradoxical. Um, but there is a scientific explanation for that. So it's important to think about coagulation assessment when there's an extensive venous malformations or a large vascular tumor, such as the KHE or tufted angioma. So you need to check the full blood count to make sure they don't have low platelets. You need to check the clotting screen, including their D dimers and fibrinogen. Because if they keep forming thrombosis, they have raised D dimer. And if they consume the clotting factors, then the fibrinogen will be very low. They just give you an idea, some precautionary thoughts before you put your knife in. As I said, you know, they increase the risk, not just the risk of bleeding, but they also increase the risk of thrombosis. Patients might develop massive PE or even die from a massive PE if you start doing the procedure without considering to provide them with some thromboprophylaxis. So, you know, in our centers, we do have very regular hematologists input, hematologists who specialize in thrombosis. We got one person who, you know, we kind of send many of our extensive venous malformations cases to her to look after. So treatment-wise, very similar to the vascular tumor, you know, it could be very simple, like physical or supportive treatment, or what we call conservative treatment. It could be a minimally invasive treatment like embolosclerotherapy, or we could do an open surgery, excision, or, you know, plus or minus reconstruction, plastic reconstruction. As well as there are also other treatments like cryotherapy, laser. There's something called electrochemical therapy now, which is getting some popularity. And as I said earlier, you know, the more genes we identify, you know, the more focus on pharmacological therapy. Treatment also needs to focus on the complications and the syndromes itself. You know, the patients, for instance, you know, may have a large venous malformation in the leg, but as a result, they get arthritis. You know, they get problem with their walking. So you should think about that as well. You know, it's just to help them to get back to their function as much as possible. Patients who have a large malformations in their, near to their airways may have sleep apnea. They might not perform well in the daytime because they couldn't, they're not sleeping well. That might make them, at risk of other cardiovascular conditions. As we know, sleep apnea can be a problem these days. Cosmesis, psychosocials, those are important for children. They might be, kind of been discriminated by their peers, and then it will affect their development. A lot of this, unfortunately, a lot of these treatments are very limited evidence, just mainly because of the heterogeneity of the conditions. There are not much randomized trials, which is just impossible to run randomized trials for this condition. And again, because it involves a huge amount of various symptomatology, complications, usually this is best managed by a multidisciplinary team. Just want to stress that, curing this condition is usually impossible, unless it's just a very discrete lump that you can excise. But even then, they have a tendency to come back. It's just because, in that part of the body, there is a somatic mutation. And then when it heals back, the lesions tend to come back. So traditionally, we cut them out, but nowadays we move away from surgical excision. Again, unless if it's a very, discrete lesion. I'll just show you this just to show what was done in the UK or England. Basically, the diagnosis is getting more increasing. Not surprisingly, open surgery remains the main treatment for vascular malformations, but the percutaneous therapy is also increasing over the time. So the open surgery usually involves excision and debulking of the lesions and potentially some reconstruction, plastic reconstruction if it's a large lesion. It's usually very challenging because if it's a arterial or venous malformations, they do bleed badly. If it's lymphatics, there's a high risk of infections, wound not healing. So these are very challenging surgery, and it also depends on the anatomical side of the lesions. If they're large, they could be close to challenging anatomy like the airways. They could be close to the major nerve, or even involve the major nerves. And the patients, may have coagulopathy, as we discussed earlier. The surgery for high flow or the AVMs, arteriovenous malformations, often aim to excise the nidus. The nidus refers to the transition point between the artery or the arterioles, which then fistulating into the venous bypassing the capillary, and those are called the nidus. And usually that's where the problem is. Not the surgery should not try to ligate the feeding artery, because that doesn't solve the problem. That actually might cause more problem, because if you don't excise the nidus, or you just ligate the feeding artery, then the nidus itself will start recruiting other blood vessels from elsewhere, and that the AVM will still keep growing despite you thought you ligate the inflow. And this is important because if we do see patients where their inflows, their feeding arteries are being ligated by the surgeons, and that leads to reduced options in the future. If you decide to do embolization, you don't have an access, through the artery to the nidus. Then surgery also has a role in terms of, being combined with other forms of treatments like the endovascular therapies. So generally, surgery is still an important part of the treatment. Just an example, this is a case I had earlier this year. Was a 6-week-old baby. Mom noticed a large left axillary swelling Initially thought it was some sort of tumor, but when the child had an ultrasound and MRI, which is I took a snapshot here, you can see there is a large venous aneurysm, which is a form of venous malformation here, and you can see it's draining into the brachiocephalic and the superior vena cava before going to the heart. So there are some thrombus here. This is initially we thought it's just a simple venous aneurysm. We ligated it. We actually had to do a sternotomy, great Ormond Street, and then ligate the brachiocephalic here, excise the whole aneurysm, and then we didn't reconstruct it. We think at this age they normally collateralize quite quickly, which at that time we were hoping for the best really, and it turned out to be fine from that point of view. The child has no trouble with the arm. There was no issue with swollen arm, even though we have excised the whole subclavian vein. Interestingly, then she also developed chylothorax, and then when we did the lymphangiogram, it turns out to be a lot of lymphatic malformations in that area as well. We think what happened is when we removed the venous aneurysm, we disrupted the venous malformation, causing a lot of leakage. It took us twice to embolize it with lipiodol to stop the leakage. We can see the chest drain here. We have to drain the chylothorax. So it, retrospectively was a veno-lymphatic malformations. If there is some of these venous malformations can be divided into truncular and extratruncular. So this is a truncular venous malformation together with the lymphatic malformations. And it's also shown on the histology. Another quick one was a 10-year-old boy treated last year who wasn't a healthy boy, not known to have any vascular malformations, and then presented to his local hospital with swollen and painful left calf. Initially, they thought it was a bleeding or deep vein thrombosis, and then the ultrasound, showed a large swelling, and then he was sent down to the Royal Free Hospital, where we did an MRI scan. Let me see if it's run. And you can see, it's a huge venous malformation here. I'll show you again. And this is the cross-section imaging. And you can see it's a huge venous malformation going down through the popliteal fossa and down to the calf. So we decided to do a venogram. When we did the ascending venogram, you can see the popliteal vein. There is an aneurysm in the popliteal vein. And then when we directly puncture the venous malformation, you can see it's all connected straight into the popliteal vein. So in the end, we didn't think. We initially started with anticoagulation because what turns out is there were lots of clots within the venous malformations, but when we stopped the anticoagulation, then the child developed recurrent DVT, so we had to put him back on the anticoagulation. So the question is, the options for the child is, if we don't do surgery, then he will be long-term anticoagulation, which is not ideal because there's always a risk of bleeding from having whole life of anticoagulation. And sclerotherapy is probably not a good option because I don't think it will be able to shrink the whole thing down, and it probably going to cause more DVT. So we decided to go for surgery. We did a debulking surgery. We debulked most of those big malformations, and then for the popliteal vein aneurysm, we plicated. We didn't think a bypass or stenting would help, so we plicated. We kind of fold it down and keep it, reduce the size of it. So we keep it on 3 months of anticoagulation, just let everything settle down, and then we stop it. We repeat the duplex scan in 6 months, And it was a smaller popliteal vein, and he was better, and he got back to his activities. So the other options that we do use quite a lot is the embolosclerotherapy, which combine embolization and sclerotherapy. So for the low flow, the venous and the lymphatics, what we do is we directly stick the needle into the lesion, like shown here, and then we check it with the ultrasound or fluoroscopy before we inject the sclerosant. For the high flow, we add a catheter angiography. We could put a femoral catheter and go to that territory and then do an angiogram from inside just to learn the anatomy. And then you could embolize it or put the sclerosant in through direct needle stick, or you can do it transarterially. And more often now, we are also using transvenous, which means you come from the venous side and push the sclerosant into the nidus. This is what we are aiming for, the nidus, where you want to go just as the artery turn into the veins. That's where you're aiming for. And there are various agents that can be used. Ethanol is a very commonly used. We don't use ethanol much. We tend to use the sodium tetradecyl sulfates. There are also like doxycycline, bleomycin, coils, or glue. Again, which agents is better? There's no evidence on the literature. In my opinion, I think it's based on the operator, the experience of the operator. If you're used to one agent, you get reasonably good results. You should keep improving yourself on that agent. At the end of the day, these agents are meant to go in to kill the cells. So and they're dangerous. So, the operator should get used to that agent, and the more he or she uses, the more experience they get. This is just to show you some examples. This is a child with the lip low flow malformation. As you can see on the MRI, there is a low flow right on the left side of the lip. So we decided to do a direct stick. We stick the butterfly needle straight into it. We check it with the DSA, and then once we're happy with the flow, we inject the STS 3%. In this case, we do tell the patients, that this will ulcerate a little bit after the procedure, and it's going to swell up. But quite often the lips have very good results. After 2 or 3 months, they get very good outcome, and they heal quite nicely. This is another case where an 11-year-old boy who had a low flow vascular malformation is causing him a lot of problems in terms of walking. He was limping, and you could argue you could cut this out, or and we decided to inject it. We inject it with an STS. First you check with the contrast. Once you're happy with the position, make sure they're not flowing down to the toes. We inject the STS. The child was very well after the procedure. You can also use it for a more complicated one. Like this child, 12-year-old boy with a right knee venous malformation. It goes into the intra-articular. As you can see, it goes into between the patella and the femur. And again, we opted for the sclerotherapy because cutting this out could be, it's going to cause a lot of damage, and it's probably going to come back. And we aim, again, we stick needles in under radiological guidance, and we inject the sclerotherapy. And it's a large lesion, so we warn the parents that it's probably going to take a few attempts. Like this child, we took about 3 attempts to get the improvement that the child was looking for, or the parents were looking for, to be honest. There are also other types of sclerotherapy. There's something called bleomycin electrosclerotherapy, which is fairly new treatment, becoming more popular in the last few years. Essentially, it's a bleomycin. The bleomycin arrests the mitosis of the cells. The cells are proliferating, so you can arrest them. But unfortunately, the bleomycin don't go into the cell easily, and they do have toxic. There's a there is a lifetime cumulative dose which you should not exceed because it runs a risk of fatal pulmonary fibrosis. And the bleomycin electrosclerotherapy basically is to cause a temporary electroporations and encourage the cells to take in the bleomycin and basically kill the cells afterwards. The preliminary results are pretty good. To be honest, I haven't used it at myself, but we are applying at the Royal Free. But the certain centers in the UK and a few in the Europes have been using it. It's not available yet in the States, but we'll see. This is something new, so it still needs some time to see if it works or not. Even though it's minimally invasive, they do carry risk. It should not be taken lightly. Patients could develop more pain post-procedure, infection, nerve injury, if it goes into the wrong place or if you damage the blood supply to the nerve. Bleeding is is possible. Excessive swelling, because these things are going in to kill the lesion and it causes inflammation. It can lead to compartment syndrome, or if the lesion is close to the airway, it could cause obstruction. So some patients needs a tracheostomy for the procedure. Ulceration, ischemia, which is, patients can end up losing fingers or leg, if it's injected into the wrong place. DVT, and also allergic reactions. So these are some of the complications. In terms of medical therapy, I do want to touch on this because this is where I think quite a lot of future treatments for malformation is coming from. So if you look at this diagram, basically, if you split it into half, on the left side here, these are usually, I say usually, for the high flow or the arteriovenous malformation. And on this right side, these are the genes that affects the low flow or the venolymphatic malformation. So there are some in the middle, which is for the angiogenesis. So this is a very popular pathway. If you go to ISWA meeting, normally show you this type of, it's a very similar picture like this. The reason why this is important is because if you look at this pathway, there are many drugs that adds on this pathway, and there's some of these drugs are being used now to treat, the vascular malformation, especially those where surgery and minimally invasive treatments become impossible or too high risk or not working. So usually then these patients are being trialed on this type of drugs. At the Royal Free, we use thalidomide here, which is an angiogenesis inhibitor, but we use it on adults only because children are growing. And we also use the rapamycin or sirolimus, which is inhibits this molecule called mTOR. So the most commonly used is the sirolimus or rapamycin. In fact, it was very commonly used in children, and it was first used in children before adults. And it's been used, probably around 2010, something like that, where, on cases where patients are basically too high risk for anything or with severe complications when the standard treatments are not working. And over the time, there have been lots of studies been done, including randomized controlled studies. Essentially, it does show some low-level evidence suggesting the sirolimus do help, in some of these cases. And usually it works on vascular tumor, lymphatic, and venous malformation. It doesn't work very well on the high flow or the arteriovenous malformation. And from my experience, it seems to work for, it can reduce pain, it reduces bleeding, reduce DVT, reduces even reduces infection, despite this is immunosuppressant. And it does show some our own experience. We should publish it, also show it improve, the patient's quality of life. So this is something interesting because we normally use this, if the surgery become impossible. or it's not working. For example, in this 8-year-old boy with P10 mutation had a foot vascular malformation. We find this very difficult to treat. Cutting it out is challenging because it's right in the, in all these delicate structures in the foot. Sclerotherapy is easy to do, stick a needle in, but somehow it doesn't work very well. Like this boy, we tried to inject it, but just didn't work. He was still using, couldn't walk in pain on wheelchair. So we tried sirolimus therapy, and then the pain improved significantly, and the child can start walking around, running around, compared to when he was on the wheelchair most of the time before the treatment. So it is something interesting. It does work just by tablets, and the patient gets better. But the trouble is, we do not know the long-term side effects. We do not know, these are children. How long are we going to carry on with this drug? So nobody still know whether, how long we should we stop it. We do stop it, and quite often the symptoms recur. So as I say, from our experience, we do get some benefits from pain improvement, reduction in swelling, improvement of coagulation, reduction of improvement and improvement of reduction of infection and improvement of quality of life. I have to be honest, they do not work on everyone. It's only some patients, so just be careful. The adverse or side effects are not common, but they unusually, the side effects are actually quite common, but usually they are mild and reversible, and and they're not life threatening from what I've seen so far. But again, the numbers is small. Other drugs are like alpelisib. Alpelisib is a very specific PIK3CA, which if you remember the diagram, it's a major gene mutation for venous and lymphatic malformation. Usually they're drugs for cancers, and now there's a trial going on in Europe and UK looking at their effects on very severe venous and lymphatic malformation that have been proven to be PIK3CA mutation. Early studies have shown some reasonable results, but again, these studies are very small, only 18 cases, so just have to be a bit careful. But to be honest, usually in these patients, they're pretty desperate, if they come to this stage. A few many other drugs like tronmetinib, which is for the high flow, the AVM. Bevacizumab again is an anti-angiogenic, and then there are also many other drugs as well. So this is where the diagram become important. Finally, I just want to touch on, which I've touched on before, the multidisciplinary team approach. It is important to have multidisciplinary team. The condition affects all parts of the body. So different types of surgeons should be involved. Different physicians should be involved depending on what the patient needs. The vascular surgeons is important here because we are normally pretty good, in terms of dealing with blood vessels from all over the body. We know we handle the vessels, when we operate. We know how they behave. So we are an important part of the team. And these days we also start doing endovascular. And we also have a lot of knowledge in terms of medical treatment, or at least so we think. But at the same time, it is important to involve other specialists as well, because we might be limited knowledge in terms of the hematology, the genetic side. We're probably not very good at the psychological side, but all these are important for the patients. And there's no fixed rule on how you can carry out this. Essentially, it's a group of people who are interested in managing this condition, and this is how we set up the multidisciplinary team. So this is the multidisciplinary team at the Royal Free. We have interventional radiologists, myself as a vascular surgeon. We have clinical nurse specialists, and we have a very good support from all the specialists involved. They might not be directly in the clinic, but if we need their help, they will, they normally will help. And we have a close network within London itself, we have our sister hospital, University College London, Royal National Orthopedics, and the Great Ormond Street Hospital has a different multidisciplinary team, which I'm part of as a vascular surgeon. And we have genetic support as well. So thank you.
Thank you, Mr. Lim, for such a fascinating presentation. Yeah, vascular malformations are a rare category in vascular surgery, and all of us either here or all over the world are really anxious to approach them. And obviously, they need a huge experience and multidisciplinary team, as you just mentioned. We got one question in the chat now, and the question is how to stop bleeding caused by coagulopathy in large venous malformations.
I'm glad someone asked the question because, it is something very important, in my opinion. And I've come across a few challenging bleeding because of not managing that properly. So I think, as I said earlier, if you see someone with extensive venous malformation, you know, even if they're not very extensive, do have a low threshold to check their clotting screen. The APTT, INR, those things are not that important, to be honest. The one that I'm really looking at is the D dimer and the fibrinogen. Again, there's no guidelines on this, but it does give you an idea. If someone has a very high D dimer, which means there's some sort of thrombosis keeps occurring in that person. And if someone, and to make things worse, if they have a low fibrinogens, means the clotting factors are being used somehow to cause that thrombosis, which means when the patient needs when you operate on the patient, or if the patient bleeds, he or she may not have enough clotting factors to stop the bleeding. I can tell you, no matter how much stitches you put, it's not going to stop. And this is where, in my opinion, I think hematologist is important, and it has to be a hematologist who understand this. Um, Essentially, interestingly, you have to give them anticoagulation. You know, the science behind this is because if you give anticoagulation, you stop those inappropriate clotting, that they're doing, and that will give, stop the consumption, the consuming of the clotting factors, so that there are clotting factors available for the place where you're operating to stop the bleeding. So that's the basic the basic side of the story, obviously. Um, yeah. So what we do is we normally make sure we give some tranexamic acid. We give them um, clotting factors, platelets. You have to check the platelets as well. I do use quite a lot of things like Surgicels, because I find stitching is not, you do stitch them sometimes, but you put some Surgicel. Sometimes you just have to press on it for a while, really, if it bleeds a lot.
And do the fact, like if you inject direct thrombin injection or flow seal and these stuff, are they going to be of any benefit? Or
Yeah, you can inject things, you can always consider doing sclerotherapy before the procedure to scar the thing down a bit, so that you got better chance to reduce bleeding. But when you start bleeding, if you start to inject things, you also worry that you inject into the wrong place, that you don't want the stuff you inject goes into the big vein and goes into the pulmonary circulation. So it's a bit tricky. Yeah. And then when it comes to venous, as we surgeons know, sometimes it's much harder to stop than arteria, because arteria, at least you can get control of the feeding artery, but venous is just bleed continuously. Yeah. And the tissues, I can tell you, is very fragile to stitch.
thank you so much. We got Ayman's got a question.
Yeah, And thank you so much. Thank you so much for the very informative presentation. You know, it's a very challenging condition, and you expert in the world in this field, given its rarity. So we are lucky to have you, Dr. Lim. So, my question is regarding if there is an associated lymphatic um, disorder, how do you handle that? Because lymphatics. I mean, it's as we all know, it's difficult to see. And the other question, I mean, in some patients with these lymphovenous malformation, maybe the lymphatics that are malformed is the only drainage for their legs. Eliminating those maybe can give like a counter effect in worsening swelling. So would like kind of to hear what's your thoughts about when the lymphatics are involved in these venous malformations. Do you address that differently, or you have the same approach, or there's any tips or tricks?
I think if it's a pure lymphatics, then it's a little bit different from venous. The pure lymphatics, depending on again, it depends on how it affects the patient. Obviously, quite often, if it's something not symptomatic, we leave it alone. If it's recurrent infection, we tend to do sclerotherapy plus the medical treatment. If it's an obstruction or leakage, then we do look at the lymphangiogram to see if there's if there's anything we could, where the source of leakage is, where the blockage is, we can address. Sometimes it's not, there are two types. It could be a lymphatic malformation, so it could be just congenital, underdevelopment of the lymphatic. So we have to make sure the diagnosis is correct because the management is different. In the very worst case scenario, we may quite often do use the medical treatment. The sirolimus works very well on lymphatic malformations. In fact, for all the vascular malformation that it works on, the best is lymphatic malformation, better than venous malformation. So we do very occasionally throw in the drugs as well. If that lymphatic malformations or venous lymphatic malformations becomes difficult to manage without the approach.
And another question I do have, I was reading a case report of someone who's treating those malformation. They're talking about, if I remember correctly, I think it was the pleomycin injecting it in the interstitial space, not necessarily inside the nidus itself. Do you guys have the same practice, or?
Yeah, the bleomycin is still preferably to inject intravascular. Um, but there are like the microcystic lymphatic malformations. You can know where you can inject into intravascular, so you inject interstitious, and in very specific, those solid type of vascular malformation like fava, things like that. So you can actually inject into the interstitial space. You saw my talk earlier. We talk about the trouble of bleomycin is it require multiple treatments to achieve the results, and it does have toxicity that you might have to be careful on. So more recently, as I said earlier, the people introduce electroporation to improve their uptake. So yeah, you can inject into the interstitial, but you cannot inject STS into interstitial. That's the trouble. Yeah.
Uh, Thank you so much. Probably related to this, and you probably answered part of all of this question. Does bleomycin work in all or only suitable for AAPM?
The bleomycin works on, in fact, the low flow that's been used quite a lot on the venous lymphatic. Usually, let's forget about the electrosclerotherapy bit. Usually tends to use it on areas where you do not want too much swelling, like the lips, for instance, close to the eyes, the genitals, where you do not want too much swelling because it can cause problem. Um, so the nice things about bleomycin, it doesn't cause much swelling as like for US STS. So for AVMs, there have been some attempt. There are some experts been using it for AVM, even the large AVM. If you think about it, the whole thing, how bleomycin works is it it actually has a mechanism where it goes into the nucleus, it arrests the replication of the DNA, and whether it's AVM or low flow, when it comes to vascular malformation, it's a proliferation. So what it does is to stop the proliferation. So this is how it works in this group, in this pathology.
Thank you so much. It's been a fascinating talk, and it's a lot of information that you can take and you squeeze it in 1 hour. Really helps us in understanding